Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello, good day, and a happy new year. Today we are going to discuss about arterial spin labeling, applications and challenges in pediatric neuroimaging. My name is Bejoy Thomas and I'm one of the neuroradiologists at the Sree Tirunal Institute for Medical Science and Technology in Thiruvananthapuram, Kerala, India. And I'm thankful to the Spin Academy for this invitation. And here we are in the southernmost state of India, Kerala, and the southern tip of Kerala. We are situated at Thiruvananthapuram. And we have the hospital wing as well as the biomedical and public health wing of this institute. And these are my disclosures. I have grants from Government of India and also research support from G Healthcare and the 2 Indian patents are pending. The objectives of the current talk are give an overview on the arterial spin labeling based MR perfusion, the clinical utility of ASL imaging pediatric neuroradiology, the spectrum of factors which can affect the quality of clinical ASL studies and the pitfalls. And we will also discuss about some quality control measures and advances and future directions. So as you know, this is a non-invasive perfusion method which doesn't use an exogenous injection of contrast media like gadolinium, and we can label the arterial water at the skull base and wait for some time to occur images to get labeled images. And we also acquire without this labeling a control images, and when we subtract the labeled images from the control images, we get a perfusion weighted image. So there are several acquisition methods which we'll discuss in the coming slides. The basic principle is again control image minus labeled image give you ASL flow map image which is proportional to the arterial transit delay and inversely proportional to the T1 decay. This is really important and we'll discuss in the coming slides. There are, like I've previously mentioned, there are different schemes for labeling methods, and the commonest ones are continuous ASL and pulsed ASL, and but currently we are using in the clinical practice which is recommended by ISMRM and European Union Consortium on ASL in dementia. Recommended sequence is a 3D pseudo-continuous pulsed continuous ASL or a pulse continuous ASL, which is actually having relatively high SNR and high labeling efficiency with the expense of an optimal SAR. And this is why we are using a 2D versus a 3D. We will explain in the coming slides. There are several other new variants of this ASL also available, like velocity and acceleration selected ASL, just got specific advantages. Territorial ASL, selectively labeling protons of one chosen vessel, where you can actually differentiate the arterial territorial supply of different arteries, which may be of use in certain clinical situations. And we'll also talk about multi-label delay ASL, which will compensate for arterial transit delay artifacts which are occurring. So this is a paper I was actually mentioning about the ISMRM perfusion study group and European Consortium of ASL dementia combined recommendation for pseudo-continuous ASL with an FSC readout. We talk about the tagging efficiency of different schemes. The pulsed ASL has got a tagging efficiency of 95%, which is the highest. What we are currently using is a pseudo-continuous or a pulse continuous ASL, which has got a tagging efficiency of 85%, and continuous ASL has got a tagging efficiency of 70%. And this is the 2D pulsed ASL, which we acquire on a 1.5 Tesla scanner. We'll also talk about this. This is what is happening in the pseudo-continuous or a pulse continuous ASL. It is actually the adiabatic inversion pulses are pulsed, so that the SAR can be limited at the expense, and at the same time you can actually get a relatively high SNR. So 2D versus 3D. Now we know the volumetric acquisition is there in 3D, and it is not slice dependent and relatively high SNR. And now I prefer 3D sequences compared to 2D sequences, and an FSC readout compared to an API readout, because you can see because of the specific advantages of a 3D sequence, and which can give a very robust clinical perfusion methods. So when we come to the ASL analysis and post-processing, ASL we get the grayscale images, which is a subtracted image, and also which can generate a color map based on perfusion heat map we can generate, which will give an idea about how much of a qualitative idea about how much of perfusion is happening in the brain, or perfusion loss is there in certain regions of the brain. And in addition, we can also quantify the cerebral blood flow from these images. And arterial spin labeling is one of the techniques which can give a very high quality quantitative cerebral blood flow measurements. So this is a sequence we use on a G Discovery 750W scanner, 3D pseudo-continuous technique. These are the other technical parameters. Use different post-labeling delay in adults and children, and I will explain that in the coming slides as well. And because the circulation time, based on the circulation time in the neonate, it can be still very high, but in adolescents and young adults, can be low compared to an older individual. And the average scan time is around 5 minutes, and this is the different post-labeling delays recommended. And this publication, you can see that it is very high in the neonate because increased, it is relatively high post-labeling delay because of the circulation time is not very high, but you can see that the post-labeling duration is much reduced in young children, and also in adults it is increased. In older individuals even more delayed. The clinical utility of ASL in pediatric neuro, when we talk about that, ASL imaging in epilepsy, it helps in localization of the substrate and the detection of interictal hypoperfusion and periictal hyperperfusion, and comparative evaluation with the SPECT and PET can be done, which we'll discuss. So when we see this, the epileptogenesis occurring from the ictal onset zone and actually spreading into the symptomatic and functional deficit zone, and so on. And we know that in the interictal phase there can be hyperperfusion of this epileptogenic zone, and in the ictal phase you can see the hyperperfusion. There are several papers comparing interictal perfusion studies based on ASL as well as SPECT and PET, and we have also recently published on PET imaging and as well as the perfusion ASL imaging in actually finding out the substrate localization in epilepsy. And for example, in this case, you can see in the left hippocampus there is hyperintensity and then some volume loss. This is a case of left hippocampal sclerosis. You can see in the corresponding ASL image, you can see there is a hypoperfusion compared to the opposite hippocampus. You can see medial temporal lobe is showing hypoperfusion in an interictal state. Whereas in the periictal stage, when you image the patient immediately after a seizure, you can see there is some swelling of the hippocampus. At the same time, you can see high perfusion of the hippocampal region, and this is what you see in the periictal phase. So another case of long-term epilepsy associated tumor, ganglioma of the right temporal lobe. You can see the tumor there. There is a faint enhancement or ring-like enhancement. You can see in the inductal phase that there is again diffuse hypoperfusion, not only in the medial temporal lobe but also in the anterior temporal pole, and you can see there is a significant interictal hypoperfusion of this lesion. We can also see this is a case of a cavernous angioma of the temporal lobe. You can see again there is associated changes, or in the opposite hippocampus you can see there is a hyperperfusion occurring in this region, and also the temporal pole on the other side is showing hyperperfusion as well as medial temporal pole. So when you have a dual or double pathology, you can also see corresponding changes in the perfusion imaging by ASL as well. This is a case of frontal FCD. When you see just narrow the window of the flare images, 3D flare images, you can very well see that the medial basal and the basal frontal, you can see there is a poor gray wire differentiation and gray matter hyperintensity, and this is actually corresponding to a low perfusion in the rectal state in the ASL. and which is corresponding with the PET imaging. That is actually looking at the metabolism. There is a corresponding perfusion deficit, and SPECT is more correlating with the ASL imaging as far as perfusion is concerned. But where you can see in the PET image is also showing interictal metabolism, which is corresponding, which is there is a coupling of perfusion and metabolism, and you can see that there is corresponding hypo metabolism in the PET imaging as well. This is a case of tuberous sclerosis. The value of PET is indispensable, especially amino acid PET. But before that, you can see ASL as a poor man's PET imaging, because you don't have to inject 2 times, not FTG plus amino acid PET. You can see that there's significant hyperperfusion of different tubers, and the seizurogenic tuber sometimes can show high perfusion, as well as the largest one showing a largest hyperperfusion as well. What the advantage of ASL is, ASL can do at the time of doing an MRI, and followed by a specific amino acid PET like alpha methyl tryptophan PET to localize, which is to be operated on this many different tubers. So this again another case of tuberous sclerosis. You can see there are multiple tubers. You can see in the right frontal region, you can see the tubers are less marked, but there is hyperperfusion. And there is a large area of hyperperfusion of the left parietal and extending in the frontal region. And you can see that the perfusion deficit is actually much wider compared to the location of the tuber itself. So when you see this hyperperfusion and hypoperfusion pattern, probably you need require clinical data as well as amino acid PET to further delineate which one has to be operated or targeted in these cases, if at all you are deciding to operate on this. Now, newer methods of treatment modalities like antagonists of mTOR pathway are available for tuberous sclerosis. So, but when they are intractable and not responding, sometimes you have to resort to surgical methods, of which this technique may be very useful in initial assessment of these lesions. So this is a case of an occipital origin seizures. In the flare imaging, when you have a casual look, you don't see anything. But when we always go back after reviewing the ASL images, you can see that there is an area of hypoperfusion in the left occipital pole. And when we adjust the windows, that means after seeing this, we go back and actually narrow the window on flare. You can see there is gliosis of the left occipital pole in this area, which is very, very subtle and otherwise may be missed. Again, this case, 15-year-old male with occipital origin focal seizures. Again, you can see there is some gliosis of the right occipital region, and you can see this medial occipital region on either side of the right occipital sulcus and the calcarein sulcus. You can see there is gliosis and volume loss. And this is what they have done. They have actually gone and actually resected this because it was an intractable seizure. And even then, patient continued to have seizures. And you see there is ASL perfusion. They are just into the resected margin. There is high perfusion. And we are not telling that this is the ictal onset zone for this. So we have other invasive data to suggest that. And after that, they have actually gone ahead and actually resected further. And then the patient has got patient became seizure free. Sometimes perioperative mapping is very, very important. And if you are not using perioperative mapping, sometimes failed surgery because the ictal onset zone can be much wider than what in anatomical substrate what we are seeing on MR. So here again, you can see in this case after second surgery there is no hyperperfusion and this child was seizure free. So they can also see in quadrantic hemimegalencephalus diffuse hyperperfusion, and also you can see the caveats of ASL and PET. You can see in this case there is a hypometabolism of the right temporal pole because PET is an interictal phenomenon. But by the time MR is done, patient had a seizure, recent seizures, it is showing a hyperperfusion. So sometimes there can be discordance because in different time scales you are doing this, and there is a PET is showing an interictal hypometabolism of the temporal pole, and it is showing hyperperfusion on the same side when you are actually imaging immediately after a seizure. But again, this is useful if you understand that the temporal relationship with the recent seizure or your video EEG findings, then you can actually localize better using these complementary modalities. This is a case in 2012 in a 9-year-old male patient had intractable seizures, EPCs, epilepsy partialis continua. You can see the left hemisphere. There is some hyperintensity which is very subtle, and there is not much of a volume loss. In fact, there is some edema of the temporal pole and temporal lobe as well as the insula, and also extending the posterior temporal regions. And in the follow-up 2014, patient continued to have seizures. Intractable, you can see the same side hemisphere is showing volume loss, and also cilium fissures are widened, and the caudate is not that atrophied. And in the subsequent imaging 2016, you can see further dilatation of the lateral ventricle and the volume loss, and you can see there is hypo perfusion of the hemisphere. And again, some areas, some islands are showing very high perfusion. This is classically seen in Rasmussen's encephalitis, where there is actually diffuse hypoperfusion in the chronic stage. But even then, some areas will show hyperperfusion, and we have a recent publication on this, whether this is active areas of seizure, epileptogenic zone, or these are active inflammatory areas, which is cannot be differentiated from ASL imaging alone. So high frequency seizures, again another case. Where is the epileptogenic zone? If you again look at the normal flare imaging, it is very difficult, even though clinical data may be suggestive. And here the perfusion ASL, we don't know whether the right side is hyperperfused or the left side is hypoperfused. You can do active cerebral blood flow measurements, but again, if you look at the clinical data as well as the electrophysiological data, and also narrow the window in the flare images, which you should always do, you can see the right side hemisphere is showing hyperperfusion. This is a case again of a encephalitic process, which is leading on to diffuse hyperperfusion as well as hyper intensity of the cortex. And we know that the right side of the hemisphere is abnormal, which is showing diffuse hyperperfusion, which is in the immediate inflammatory phase. Again, it's an 8-year-old male, previously normal, and previous MR was available for comparison. There was reported as normal, and there was no finding. But in this case, you can see the right frontal opercular region, there is hyperintensity, poor gray differentiation. Initially, we thought that it is again on the lateral aspect. You can see this. Initially, we thought that is a dysplasia, but reviewing the previous imaging, there was no dysplasia there. And this is the interictal PET imaging. You can see there is hypometabolism in this region. This ictal, periictal perfusion ASL image, you can see very high perfusion in this area. So also you can see that it is actually spreading more posteriorly. So the perfusion may not be exactly showing the substrate itself. There can be significant the spread if electrical activity corresponding perfusion increase also can happen. So it's again how interictal PET as well as nictal perfusion imaging is actually helping us to localize in this case, and this case was proved to be autoimmune encephalitis. Another case, a caveat, you can see there is a hippocampal sclerosis, there is volume loss, not much of hyperintensity, but you can see the temporal pole is also abnormal. This amygdala is bulky and there is hyperintensity, and there is hypoperfusion of the temporal pole, but there is hyperperfusion of the posterior hippocampus as well as temporal region. So we tend to think that this is the postictal phenomenon, the substrate is much posterior. In fact, what is happening is that electrophysiologically as well as invasive data, the epileptogenic zone was much anterior, and when we are actually imaging after a seizure, it is actually propagated posteriorly and we are catching up. It is the difference between an ictal SPECT as well as ASL. In ictal SPECT, if you are injecting less than 20 seconds, it's going and actually ligating to the area of the ictal onset zone. Even if you image later, we are actually looking at the substrate where the ictus has actually originated. Whereas in ASL, you are not actually you are using only an arterial labeled arterial water, and with the time and the propagation, this electrical activity can move. So also the perfusion activity can actually propagate. So you will not be always seeing the ictal activity, the ictal onset zone on perfusion imaging. There can be significant discordance between electrophysiological data and perfusion imaging. And this is another case where it's bilateral or urticaria post hypoxic sequelae. We can see this case the glass is more on the right side, and the interictal data as the ictal EEG data was more pointing towards the right occipital pole, but you can see the hyperfusion which is actually happening on the left side. Possibly there is bilateral uh, mm, metabolic abnormalities as well as perfusion abnormalities, estrogenesis, or it can be propagation. We are not very sure. So you cannot actually rely on ASL data alone, but you have to look at it in the light of clinical as well as electrophysiological data. This is another case where again you can see the dysplasia, you can see areas of hyperperfusion in the frontal region, hyperperfusion, as well as again pointing to whether this is a substrate or an epileptogenic zone or it's actually propagation. It's not very clear. Coming to other mimics as well as other the vascular abnormalities is a case of hemiplegic migraine. In the vasodilatory phase, you can see there is a increased vascular prominence of the left hemisphere. In this case, especially in the MCA territory, there is a hyperperfusion, which is again may be missed with other pathologies. So you should be aware of this. In the immediate vasospastic phase, there can be hyperperfusion. In the vasodilatory phase, there can be hyperperfusion. Can also show whatever the perfusion imaging, the gadolinium perfusion imaging can show. You can see in this case of a Lermite-Duclos disease, there is increased CBF, which again is developmental abnormality. It's not a high grade lesion. Compared to tumors, we know that we look at the cerebral blood volume for grading, and you can see the nasal. You directly cannot actually get the CBV, but you can look at the CBF, and there are several papers which says that which compares the gadolinium enhanced perfusion imaging as well as ASL, and ASL is particularly useful in children in actually showing the grade of tumor. But the problem is that if there is a postictal phase, even in low grade tumors, there can be hyperfusion, and ASL is not always comparable to a gadolinium perfusion imaging in differentiating a high grade tumor versus a postictal state. Another very important advantage or disadvantage is that compared to contrast agent water diffusible tracer or ASL, CBF measurements are not very sensitive to permeability changes in blood-brain barrier. So in perfusion, gadolinium perfusion imaging, DSC perfusion as well as DC perfusion, we would like to image the permeability as well as the blood-brain barrier leakage, loss and leakage, and which is not really possible with ASL imaging. And there are several artifacts which can come when you're in the child is, especially in the pediatric age group, when you're doing ASL with the intubated patients. You have to be very careful in interpreting. Uh, uh, they tend to use a Nair column, especially in um, these intubating techniques, and it can actually produce susceptibility and your labeling efficiency. And also, most of the time, they will tend to hyperextend the neck, and which is again change the labeling plane. Ideally, you have to have a neutral position, and you have to label parallel to the ACPC line, and you cannot actually tilt the ASL labeling plane in most uh, vendor supplied ASL methods. Again, you can see these effects of anesthesia depending on the level of anesthesia and the anesthetic agent used. There can be differential perfusion of the posterior circulation as well as the anterior circulation. They basically gaseous anesthetic agents are predominantly propofol because they have a different vasodilatory properties. Again, this is what I was talking about. Depending on the extension of the neck, there can be change in the labeling plane, and you can see depending on that the occipital perfusion can be increased or decreased. So this is a near artifact. If you are not aware, you will tend to misinterpret the data. Another 7-year-old female with seizures. We had this when we did this. We saw that there is diffuse hypoperfusion of the left hemisphere, but it was not clinically corresponding. When we look back, this was the problem. This is an artifact. You can see this is a child who was intubated, and in the pilot tube there is a small MR compatible or compatible small spring, But even then, this metallic spring, whether it's not uh, for a magnetic, but we can produce artifact, and this the labeling is very very sensitive process, and this the metallic spring in this pilot tube on one side can produce poor labeling. This is what happens after we tape the pilot tube with the central part. You can see there is much improvement in perfusion. The clinical, now we move on to the clinical challenges in quantitative ASL. There are different challenges because it's a heavily technique dependent imaging, and there are several artifacts which can arise during labeling, like ineffective labeling, CSF labeling, susceptibility artifacts, and coil insensitivity, arising during transit, loss of spin label, intra-arterial signal, venous ASL signal, and all, arising during readout, motion artifacts, blurring artifact, or smearing artifact, and occipital hyperperfusion, which is beautifully described in this paper from Gregory Saharchuk's group. And this is what is happening if there is a susceptibility artifacts for this dental hardware. You can see in the labeling plane, if the susceptibility artifacts are there, there will be very poor labeling, and ineffective labeling lead on to very poor perfusion data. And this can happen in one side because of the dental hardware on that side. You can see there is a complete hyperperfusion, and if you do the angiogram looks okay, and this should not again be misinterpreted. You have to always look at the source images as well as the gradient susceptibility images, and also if possible a 2D PC angiography, whether to see that the vessels are normal. Again, another case where you can see there is a susceptibility artifacts on the side, and which is reducing again due to a pilot tube, and this we have to be very very careful. This can produce this. So tortuous carotid arteries and skull base can produce ineffective labeling, and there can be continuous churning of these labeled spins if there is very tortuous or loops, and in those cases, if you're suspecting, you can immediately run a fast 2D PC angiography to see there are no vessel abnormality. CSF labeling can produce ring of fire artifacts because the CSF is actually coming from the labeling plane into the imaging plane because of the CSF pulsation during diastole and systole, and can produce a ring around the brainstem. It's called a ring of fire artifact. Can also show some of smearing artifacts, which we'll talk about later. So what happens if you do ASL after gadolinium injection? There will be shortening of the T1, and we know that the shortening of T1, there will be the loss of signal, and you will not see any ASL signal. So if you are doing ASL perfusion imaging, it has to be done before actually injecting contrast. So you cannot do DSC perfusion followed by ASL perfusion. If you want to do that, you have to do ASL perfusion first, followed by gadolinium injection. So this is what is happening. So decreasing blood T1 with age, and the high T1 values in female compared to male. So all these measurements are very very important. Measuring blood T1 is very important when you are actually running a research sequence. Not really important when you are running a clinical sequence, except the fact that when there is drastic reduction of T1, like in gadolinium injection, you can have a complete loss of signal. Transit delay, because there can be transit delay due to various factors, including physiological factors like cardiac failure, raised intracranial pressure, just leading on to or a tortuous or a stenotic vessel, which is not. So you can actually see that the different post-labeling delays will produce a different optimization of the parenchymal perfusion, which is also depending on the age of the child, which I have actually described previously. The 25-year-old male encephalitis with herniation of the brain, there is a significant raise in intracranial pressure. There is significant delay in perfusion. When you are using the standard sequences, you can see hyperperfusion. We are still seeing only perfusion in certain vessels. And this is the arterial transit time artifact. And this artifact can be seen in a trapped ASL signal. You can see that there is MCA occlusion. And there is, you can see that there is an older patient. You can see there is a MCA cutoff, and because of that, there is no perfusion happening. And you can see there is the trapped ASL is getting trapped in the proximal vessel, and this is the trapped ASL sign. And hypoperfusion can be due to carotid stenosis, and we should not attribute always to the parenchymal abnormality when you see a hypoperfusion. So the same thing can be produced by very tortuous arteries or a very stenotic arteries. So that is the importance of running a quick angiography sequence, especially with the 2D EPC angiography. You can do it in seconds, and so it's very, very important in putting perfusion MR data. There is an artifact called border zone artifact, which is normally seen in the anterior, between the anterior and the deep and the posterior superficial as well as deep watershed areas. You can see hyperperfusion, which can be normally seen. So it should not be. This post-day labeling delay, time selection is very, very important. For example, if you select in an adult patient lower post-labeling delay, you'll see only signaling the arteries. But with optimal optimization, especially in an older patient, you can see 2.5 second delay is used, 2525 millisecond delay is used. You can see further better perfusion of the parenchyma. Blurring artifacts, blurring artifacts. This is a particular artifact when there is actually stagnation of the vessels, stagnation within the vessels, or for example, an aneurysm or a dural fistula. There can be smearing of artifacts which are occurring in the Z direction. We think this is due to Gibbs ringing, and there are different explanations for that, which is not confirmed yet. This is a case of a dural fistula. You can see again smearing artifacts in a high-grade dural fistula. Same thing can happen in an aneurysm where it's actually spins are churning. You can see the smearing artifacts, which sometimes will be useful in actually making a diagnosis. So there can be artifacts, especially motion artifact. In the patient motion occurs because of the spiral readout. You can see this artifact, and if you are interested in knowing about these artifacts and their remedial measures, we have recently published this article, and which you can go through. So limitations of routine single delay ASL is that may underestimate cerebral blood flow, and arterial transit time and mean transit time could not be estimated in the normal ASL, single delay ASL. No information regarding cerebral blood volume because you can only calculate the cerebral blood flow, and may miss small lesions, and they're prone for many artifacts like you have actually mentioned. The answer to some of these problems is a multi-delay ASL, EASL. It's work in progress with the Chi Healthcare. We have a research agreement with them, and we have actually recently done some work on that. Multiple acquisitions at different post-labeling delays to overcome transit delay artifacts, and you can measure the transit time adjusted CBF map or a TCBF map, and a transit time and transit delay map. You can also estimate the transit delay map. So these are the parameters when we are using a 7 delay ASL, and this is an experimental process. Now I think it is available as for clinical use as well. But again, it is actually can throw more artifacts unless you're not optimizing it. So this is multi-delay ASL sequence. You can see in the grayscale image as well as the CBF map. You can see there in the transit delay corrected CBF, you can see there is significant hypoperfusion of the left hemisphere, whereas in the arterial transit time map, you can see this transit time is actually increased. So you can also measure the transit time map as well as a transit delay corrected CBF map as well. So this is a case of vasospasm. You can see left M1 is not feeling very well, and you can see transit time delay corrected map. This is there is significant hypoperfusion and there is a delay. That means we are very sure that it is not due to proximal occlusion, but this is a true perfusion of the parenchyma, which is not happening. So because we are actually correcting for the delay with multi-delay ASL. And if you can see this, you can see the difference between multi-delay and a single delay, and you can estimate further the blood flow better. And this is a case of a parietal AV malformation. You can see there is increased perfusion in this because of the shunting to the venous side, and you can see that the transit delay map is actually there is a reduced time, and is useful. So what are the importance? We can actually estimate of an arterial CBV from this. So this is how it is. If you measure the mean CBF multiplied by arterial transit time from the equation, you can get a CBV. But this is not an RCBV because it is actually an arterial CBV, because you are not actually doing the deconvolution or other complex methods to diagnose. But you can get a arterial CBV if you are using multi-delay ASL. So this is a case of a periventricular leukomalacia. You can see the ASL, there is significant asymmetry between two sides. We tend to think that the left hemisphere is abnormal, but when you do EASL, you can see the perfusion is relatively normal, and this is actually due to most likely a transit delay due to a delay somewhere in the proximal vessels. The advances, there are different acquisition methods, multiband technique to improve the SNR. Compressed sensing is coming. Non-spatially selective ASL and velocity selective ASL is coming. You mentioned recently, acceleration selective ASL is also being tested. ASL fingerprinting is coming, and also ASL is being used to study the networks in epilepsy, and more advanced sequences are used for research in epilepsy and other areas. To take home message, ASL doesn't use non-ionizing radiation, doesn't use exogenous contrast, so it's a very useful and a repeatable technique especially in pediatric population. In myomyelitis disease may be useful again, but multi-delay ASL may be more useful because to estimate the CBF of the parenchyma mm, adequately, and the ASL based CVR measurements are also possible, and these are the advances, and an absolute quantification of cerebral blood flow is possible with the caveats because it can be affected by the proximal arterial stenosis, increased cerebral intracranial pressure, or because of these metabolic changes, but it can be alleviated to a certain extent if you are using a multi-delay ASL. Careful about delay times, artifacts, and quantification. The most important thing is you should understand the possible artifacts and their remedial measures, and a continued research is happening in this field. With that, I would like to thank all my colleagues who have actually supported, and G Healthcare for the research support, and thank you all for your kind listening, and thank Spin Academy for this opportunity once again. Thank you.